Hello, everyone, and welcome back to It All Starts Here, a podcast focusing on the communication and education of topics in reproductive science and women's health. I'm your host, Olivia Moir, and we are back here today at the Institute for Women's Health here at UCL. And today we're going to be talking about giving birth, and specifically the different kinds of interventions that might arise when you're giving birth, with none other than the wonderful Dr. Dawn Parris. Dawn is a clinical fellow and obstetrics and gynecology doctor here at UCL and UCLH, where she's currently undertaking a PhD to learn more about one specific type of birth intervention, which involves the use of forceps. Today, we're going to be diving into more on this and the different birth interventions, including what these interventions actually are, and some of the pros and cons of each, and also just some background on how these different methods or interventions may come into play when someone is giving birth. I'm so excited to get into this with you today, Dawn. I know so many people are so curious to learn more about what it actually means to give birth and the different ways that this can happen. But first, let's hear from you on how you got into this and where did it all start for you?
Hi, thank you for having me. I guess the question of how did it all start? Obstetrics and gynaecology, I have very strong female role models in my life. My mother, my grandmother, my great-grandmother, she only passed away a few years ago. She was incredible. And so I think that led me to wanting to work with women for women. And obstetrics and gynecology really does that. There are lots of female leads compared to other medical specialties, which I found really fascinating and inspiring and something that I could see myself doing in the future. I like practical skills. I can't sit in front of a computer for a long space of time. I like doing things with my hands. I like I said, working for women. So obstetrics and gynecology was the perfect blend of everything. How I got into the PhD and the research element, if I'm honest, I actually never had any plans to do a PhD. I saw the job advertised when I was coming towards the end of my obstetrics and gynecology training, and one of my favourite practical skill to do is turning babies in the late stages of labour, rotational vaginal birth, that we'll talk a little bit more about today. And the PhD was all about that, and it was just perfect. So here we are, about 3 years later, and it's been fantastic. So if anyone is out there who's thinking, should I do a PhD, should I not? Absolutely, you won't regret it, even if you're someone like me who came into it relatively later on in your training career. Definitely do it. The door is still open.
I love that so much. And I feel like you really highlighted a key thing. It's just like so much of this goodness comes out of not having a plan. And especially on PhDs, I feel like you hear a lot of mixed reviews, but I think when it comes down to it, if you're really passionate about the topic, it's definitely worth your while.
Absolutely. If it's something that you love, it's 100% worth it.
I love it. I love to hear that. Amazing. So now to get into this topic of today, I think a good starting point on this might just be outlining what we mean when we say the different ways or methods used for giving birth.
So there are different ways that women can give birth. The common one that many people will be aware of is a spontaneous vaginal birth, a woman who goes into labour and then goes on to have an unassisted birth. Often in the UK, if it's uncomplicated, her baby will be born by a midwife. The other way of having a baby vaginally is an assisted vaginal birth. This can be with either forceps, which are like spoons that go on baby's head, or a suction cup called ventouse. Not many people actually talk about assisted vaginal birth, but it is really common. Around 1 in 3, 1 in 4 women having their first baby in the UK will give birth with an assisted vaginal birth. In total, for all women, including women who've had a baby before, as well as women having their first baby, around 1 in 8 women in the UK will have a birth with assisted vaginal birth. So super common. People don't really talk about it. Mm-hmm. And the third way that women can give birth is by a caesarean birth. There are different types. You can have a planned caesarean birth, or you can have an emergency caesarean birth during labour. And in the later stages of labour, when the cervix is fully open at 10 centimetres, you can also have an emergency caesarean birth at full cervical dilatation, which we'll touch on a little bit later on.
So interesting. And I think well, two things. But you were saying, I mean, and it's just such a theme, it feels like, across all of the episodes that I've done, is just this is common, but it's also not talked about. And I feel like it would be good to hear. I mean, I'm sure there's different opinions and controversies on that in this specific area. But I mean, why? Like, what are some reasons maybe why it's not talked about as much?
I think there's a real drive to have a spontaneous vaginal birth, which is fantastic. As many of us as birth practitioners, we would want to support that as much as possible. There are times when it's not. In the case of assisted vaginal birth, the common reasons that this can be indicated is the woman's labour progress can slow in the pushing stage of labour when the cervix is fully dilated. And so that can be one reason that we can offer to help her to have her baby. A second reason, which again is quite common, is that the baby can become distressed during the late stages of labour, and that can also be a reason why we can lend a hand. Also, another indication can be a woman gets tired and is exhausted. And the last reason that's less common is women have a medical condition that prevents them from being able to push or to prevents them to be able to push for a long period of time. And so again, we can assist them to shorten that pushing period.
That's really interesting. So I guess part and parcel with, what are these things is, of course, well, which one do we choose? And is there a choice? And, so many questions on that. Which one is there a better option, a best option? Tell us more.
Women always have a choice in every intervention that they are offered. Women are given choices and options, but there are circumstances where one intervention could be a better suited than another. There are pros and cons to everything, of course, and it depends on the clinical scenario, which is, of course, nuanced for everyone. Broadly speaking, for example, an assisted vaginal birth with things like forceps, they're very common in the UK. Other countries around the world don't use forceps as much as here in the UK, like, for example, in France, Germany, the US. Obstetricians aren't really trained in them, but here we are. They are used frequently in clinical practice. One reason that can make an obstetrician to suggest this as an option, for example, over a suction cup called Von-Too's, can be, for example, if there's swelling on the top of the baby's head that can develop during the stages of labour, which again can be normal, but it can prevent a suction cup from working quite so well. Likewise, if the baby's head is a little bit higher up in the mum's pelvis, this can also be a reason why forceps may be used over a suction cup called Von-Too's, as well as the types of pain relief that a woman has already. If she has a good working epidural, then an obstetrician may, for example, say, you've got a good working epidural, you are comfortable, perhaps forceps might be an option, or a better suited option. If she's got less pain relief on board, then, for example, the suction cup could be a better choice. Ultimately, it is, of course, up to the woman, but what we want to avoid as obstetricians is using more than one instrument or the instrument that we use to fail. What that means is, if, for example, we try a suction cup and it doesn't work, then if it's clinically appropriate, we can change to using forceps.
Right.
But if that happens, then the baby is more likely to have trauma, which is one of the downsides of assisted vaginal birth. And likewise, if the either option fails, then again there's the chance of the mother going on to have a caesarean birth at full cervical dilatation, which again can carry more risks for both mothers and babies, not only then for that birth at the time, but in particular, and a caesarean birth at full cervical dilatation carries additional risks into future pregnancies, more than a caesarean birth, say, for example, at 3-4 centimetres dilated. These risks are a higher chance in future pregnancies of late miscarriage and spontaneous preterm birth, which can be recurrent and resistant to treatment, which can have really sad and devastating consequences for families in the future. So what we're trying to avoid is, if we can, of course not always possible, is to not have a situation where a mother or baby is harmed, and likewise thinking about the future, trying to prevent any harm in future pregnancies.
So interesting. And I learned about that a little bit in my master's, and remember just thinking like, I feel like people don't think about that, obviously everything in life, there's immediate and then long-term consequences. But when it comes to giving birth, I feel like there's not a lot of discussion, whether it's online or just within different communities about, the different sort of effects of these different ways of giving birth. And I think, at least for me, up until pretty much last year, just thinking that there was equal amounts of safety and there wasn't, any downside to certain interventions. And yeah, I think that there's just different bits of knowledge around, giving birth in general and the different priorities and focuses of the patient versus of the clinician. But we'll get more into that afterwards. I think something that you mentioned at the beginning, so much really interesting information that you just said, but at the beginning you were talking about the training of obstetricians in the delivery and the different birth interventions. So you said in the UK that it's common that people are trained for the use of forceps.
Yeah.
I've always been really curious. I think so many people of us, so many listeners are as well, is just like, how does that all work? You become an obstetrician and where does this training come in? And is everyone trained to the same standard? How does that go?
Yeah, great question. In the UK, how we're trained is we will first often practice on models that are model patients. They have a fake baby, a model pelvis, and we can practice different scenarios on these models of how to become acquainted with the instruments, what this feels like, how to use them in practice. Then we'll move on to under supervision, performing forceps or assisted birth with von 2s, likewise on patients, as said, with supervision. And then once we are deemed competent by the training portfolio, then we will go on to perform these ourselves independently. What my area of interest is, as part of my research, is improving the training, particularly of these models that we were talking about, for assisted birth with forceps, and also making devices to make assisted vaginal birth safer. For the training element, we have a collaboration with two teams of engineers here at UCL that have developed a robotic and virtual reality simulator of what's called manual rotation. I'll briefly explain what that is. Babies in the late stages of labour should, if they've read the textbook, should come with their face facing down towards the mother's back. And that's the safe way to give birth with forceps or von 2s. Around 1 in 25 babies haven't read the textbook and their face is looking towards the mother's hip or looking upwards towards her abdomen, also called back to back or stargazing. And these women are at higher chance of having an obstetric intervention to help their babies to be born, either turning the baby's head vaginally by an obstetrician or a caesarean birth at full cervical dilatation. So it's essentially a slightly more complex assisted vaginal birth. And one of the ways, the most common way of turning the baby's head in the UK vaginally in those late stages of labour is by hand. And often it's then followed with forceps or von 2s to help guide the baby's head out after that. But that process of turning the baby's head is called manual rotation. As I said, it's the most common rotational method in the UK, but it's the most likely to fail. So that's how I became really interested in how can we improve this technique in the training for obstetricians. So what we developed, as I said, with this collaboration is a robotic simulator that is a model baby's head attached to 3 robots that can provide the resistance to the turning of the baby's head. But it can also, these robots can record your interactions with them. Basically, how quickly you're turning the baby's head and how accurately you're turning the baby's head to look downwards towards the mother's spine. The current models can't give you any kind of feedback like that. The second element is the virtual reality headset. I don't know if I can say the name of the actual brand, but it's a well-known virtual reality headset that you will have seen being advertised. And in that, these obstetricians can see the virtual reality operating theatre, which can be individualized to look like any operating theatre anywhere in the world, from the appearance of the ceiling tiles to the view out of the window to the floor itself. You can add in sounds to make it even more realistic and to make it even more like where you're working, like the sound of the baby's heartbeat monitor, the chatter of the other theatre staff, and so on. And the final element of this is a surgical glove that has got 4 sensors applied to the tips of the fingers and to the top part of the palm, so that we can try to understand where force is being applied through the operator's hand and how much force they're using. Because if you use too little force, then you might not be able to turn the baby's head appropriately when you should have been able to. Again, risking an intervention not working and needing to have a cesarean birth at full dilatation. Or applying too much force or through the not ideal part of the hand, and again risking trauma to the baby's head. And so all of this, the robotic simulator, the virtual reality headset, and the glove with 4 sensors, we have used and developed together, as I said, with 2 teams of engineers. And so far, the feedback has been very positive from some preliminary studies that we've done. Watch this space for the publication. And we hope to be able to roll this type of setup, this type of simulator out into other obstetric procedures, like turning with special forceps called Keelan's forceps, or practicing, for example, when there's difficulty delivering the baby's head at cesarean birth.
Wow. I mean, I don't know about everyone listening, but I'm blown away. That's insane. I just can't believe the amount of technology that has gone into that and how advanced it is. I mean, I feel like so many different areas of medicine, there's a bit of a cultural, technology lag sometimes, because there's just, so many reasons for that. No blame at all or shade at all. But yeah, that's amazing. It's so interesting. I'm so curious. I'm going to have to come and see this one.
We would love to have you in the lab. I should say that I totally agree that medicine can be slow to advance, particularly intrapartum care during labour in obstetrics is very slow. If you ever go to a medical museum, my family are medical and that's what we do for fun. So if you ever go and you see, for example, forceps in an exhibition, they look exactly the same 200-300 years ago as they do now. So it's really important that we try to say, you know what, times have moved forward. What can we do to make this procedure safer?
100%. That's just so interesting. Learned so much already. So I think circling back to, what you said about getting the baby in the right position, what does that mean? Like, why does the baby have to be facing a certain way? And what is the safety kind of around that? And what would stop someone from delivering? And also what would happen if someone were to deliver in that other kind of incorrect position?
So as I said, most babies, if they've read the textbook, will come with their face facing down towards the mother's spine. It's how we as obstetricians are able to identify that, and midwives as well, is through examination, vaginal examination. So feeling the top part of the baby's skull. Babies, unlike us as adults, don't have one fused skull bone. They have multiple skull bones. And it's the lines that connect the skull bones and the soft spots. There's one big one at the front that people might be familiar with, and also a smaller one at the back. And so it's the shape of these 2 soft spots and how many bones are coming together and the orientation of these 2 soft spots that through vaginal examination that we are able to identify which way the baby is looking inside the mum's pelvis. On top of that, what's actually more accurate currently is using an ultrasound scanner to also confirm our vaginal examination findings, again, by looking at different landmarks of the baby. This process of determining which way the baby is looking is actually, through vaginal examination, is actually quite inaccurate. It's quite subjective. We are incorrect around 30 to 70% of the time, which is quite a lot. But when the baby is looking, for example, to the side or backwards, back to back, the reason that it's more difficult for the mother to have the baby vaginally is to do with the diameters of the baby's skull. When the baby comes with this part of their head coming first and the top part of their head, it's a 9.5 centimetre diameter, which is enough space to fit through the mother's pelvis, usually. If they're looking sideways or back to back, then those diameters are bigger. If they're, for example, back to back, the diameter that they're trying to come through, a 10 centimetre space, is actually about 11 centimetres. So if your maths isn't so good, depending on what time of day you're listening, 10 doesn't fit through 11 centimetres. And that's why it can be more difficult for the mum to give birth if the baby isn't facing in quite the best position. Right. And that's why it can be indicated that we can help mum to either turn baby, or if that's not possible, a cesarean birth at full dilatation.
So interesting. I feel like all my life I've just been like, why do we have to wait for, you hear in movies or TV, it's like, oh, the mum is 10 centimeters dilated. It's like, we're ready to go. And it's like, what is this measure and why are we waiting for that? So thanks for that clarification. So cool and interesting. So I think also something that I've been just really interested to ask you is more on the other type of, medical intervention when it comes to giving birth, which is cesarean sections. So I think something that, again, I learned about in my master's is there's different prevalence of this in different countries for different reasons. I would love to hear, some of the kind of pros and cons, let's say, of cesarean section. And maybe for anyone listening that doesn't know what this is, again, just a quick refresher on what that actually is.
Yeah. So cesarean birth is when a baby is not born vaginally. They're born through an incision on the mum's abdomen, usually a horizontal cut around the bikini line, roughly 10 centimetres in size, and then a cut on the womb itself. There are lots of different reasons why cesarean birth can be indicated. And one of the things that is becoming more common in the UK is maternal request. This has been a change in time. Even I'm not that old. Even during my career, we previously had to work quite hard to approve a woman having a cesarean birth for her own choice. But now, in the last particularly 2-3 years, since some national reports, the tide has changed, and if a woman wishes to give birth by cesarean birth, then that can be facilitated. There are pros and cons as for anything in life. Some of the common reasons that a woman may choose to have a cesarean birth, for example, things like a previous cesarean birth and not wanting to try for a vaginal birth again, or having had multiple cesarean births that again could be more risky for her to try to give birth vaginally. Other common things are the baby being breech, so coming bottom first as opposed to head first. And likewise, during labour itself, for example, the baby becoming distressed during labour, signs of infection, or again, the labour not progressing as quickly as expected. Some of the risks of having a cesarean birth are things like increased pain afterwards, a longer recovery period compared to a cesarean birth, a vaginal birth. Most women will be in hospital a couple of nights after a cesarean birth without complication. In comparison, if a woman has an uncomplicated vaginal birth with no other medical problems for her or baby or anything like that, the earliest time that she can be discharged is after 6 hours. So it's a bit of a comparison. Likewise, a higher chance of bleeding after cesarean birth compared with vaginal birth, higher chance of things like blood clots in the leg or lung. Importantly, it's also thinking about things like future pregnancies that we were talking about before. If a woman has had one cesarean birth she's at higher chance of having another cesarean birth in future. If she goes into labour after having had one cesarean birth, there is a 1 in 200 chance of the womb opening at the scar on the womb, and this is called scar rupture, also called uterine rupture, which is sadly a life-threatening complication for both mum and baby. If we use things like a hormone drip during a future labour, it actually increases the risk, approximately doubles the chance of a scar rupture in a future labour to roughly 1 in 100. So we are quite cautious using a hormone drip in particular in a future labour after caesarean. There's also the risk of scar tissue formation, and with each increasing number of cesarean that a woman has, there's more scar tissue. It's not necessarily just for future pregnancies, but say 20, 30 years down the line, a woman needs other abdominal or pelvic surgery, like an operation to take the womb away, for example, called a hysterectomy. That scar tissue can also put her at higher risk of complications and a more difficult procedure. Again, thinking long-term into the future and not just for pregnancies itself. Again, with each increasing number of caesarean birth that a woman has, she's at higher chance in future pregnancies of problems with the placenta, like a low placenta called placenta previa or a stuck placenta called placenta accreta. They can be life-threatening complications for mum and baby. And they're not that common, the low placenta, placenta previa, or the stuck placenta, placenta accreta, after 1 or 2 caesareans, but more common after things like 4, 5 or 6. So if a woman is thinking of having quite a large family, again, it can just be something for her to bear in mind when making these decisions. Right. Because as we would say, your decisions are only as good as your information for whatever decision you make. In particular, focusing back on caesarean birth at full dilatation. Yeah. This is increasing worldwide. And one of the reasons for that is decreasing skills and confidence in assisted vaginal birth. In particular, the more complex procedure of turning the baby, rotational vaginal birth. And as I mentioned before, these types of caesareans do have those additional risks, even beyond a routine caesarean, even an emergency caesarean in labour. These specific ones carry more risk both at the time and in future pregnancies. So it is important for us as obstetricians to try to think about, and society as a whole, to try to think about ways of optimising when a caesarean birth is done, in my opinion, because of these additional risks and complications that can happen.
Right. So interesting. So I guess the sort of key message I'm getting, and just correct me if I'm wrong, on your research is essentially if someone's baby hasn't read the textbook, as you say, and they're not in the correct position, it's giving obstetricians the training, skills, competence, practice to be able to turn the baby rather than immediately going for the cesarean section because forceps are considered the better option or, a more suitable option for future.
Yeah.
Okay.
Absolutely. So if an obstetrician is skilled and trained, then yes, being able to have them have that confidence to at least see if it's possible to assist the birth with either forceps or von-2s, as opposed to straight away just going for delivering the baby by a caesarean birth at full dilatation. Of course, for all babies, it's not always possible that they can be born by forceps or von-2s, but at least having an obstetrician who is skilled and able to offer that option to mothers.
So cool. It's just so interesting. And I think as well, obviously this is coming, this episode and this information is coming from so much education and background and practice in this field. But then thinking about it from the perspective of the patient and the public, for example, I think, I'm not a mother and I haven't given birth, but I think a lot of the reason perhaps sometimes that people would pick, if they have the choice, a cesarean section maybe comes down to the pain element and the fear of vaginal birth. And I guess I do think it's important that we touch on that and, just your perspectives on that or sort of any kind of, perspectives or opinions or advice you can give in that area.
Yeah. I think you're absolutely right in what you're saying, that people can be afraid of pain and also people are scared. It is It's something that's outside of our control, both as a mother giving birth and also us as obstetricians. I can't predict what will happen in any woman's labour, but it's about providing the best care that we can. My own feeling is that I think a lot of people would benefit from improved education, not only when people are pregnant and the women and their birth partners, but I do think, for example, in school, there was a lot of emphasis. I went to a girls' school. There was a lot of emphasis on how not to get pregnant. But I think there's a real gap in saying this is what's normal for being a woman. This is what's normal for being pregnant. This is what's normal and can happen during your labour. This is what can also happen if things don't quite go to the plan that all of us had hoped for.
Yeah.
As well as things like how long it can take to get pregnant, when to see your GP. That's a whole other element. But I do think a large part of it, in my own feeling, is education for women, their birth partners, and society as a whole. I do also feel that there's a lot of disinformation in general, but particularly about women's health. And that's why I think a podcast such as this, with hopefully accurate information, evidence-based information, can be used again to provide that education, because is what can help enable women to make the right decision for themselves.
Yeah.
The right decision for me, the right decision for you, the right decisions for somebody else can all be totally different. But so long as we have the right, good quality, appropriate information to help us make that choice, that's the best thing that all of us can hope for.
Yeah, 100%. It's so well said. And it is true. I mean, as you said, your decisions are only as good as your information. So I guess sort of wrapping this up and feeding more off of that in terms of the perspectives of patients and the public, do you find that there's any sort of misconceptions or beliefs that people come into the hospital or the clinic with when they're about to give birth, or, in advance of that, even that you just want to clean the slate and get the record straight here?
The most common one that I come by in my care, I would say, is people not wanting forceps or von-2s. I must stress, I don't think it's on anyone's birth plan to have a birth assisted by forceps or von-2s. Many people will have a preference for spontaneous vaginal birth. Many people will have a preference for planned cesarean birth, but no one, I assure you, no one comes in expecting to have an assisted vaginal birth. And what is quite difficult is having those discussions in the late stages of labour, when, for example, a baby is distressed and clinically assistance is indicated, whether it is an assisted vaginal birth or a cesarean birth at full dilatation. But having these discussions after hours of labour, fairly often in the middle of the night, when a woman fairly often can also be in pain as well. These can be quite difficult scenarios to navigate, both for us as obstetricians and of course for the mothers and their families as well. So again, I think that forceps and von-2s are safe instruments, and it's about people being aware of that option being offered to them in the late stages of labour.
Yeah, it's so well said, and just such hopefully useful information for anyone listening. I appreciate you coming on so much. This has been so informative and helpful, and just a great overall discussion. So thank you.
Thank you very much for having me. It's been my pleasure.